everyone. Thank you for joining us today and welcome to today's webinar, National Post-Traumatic Growth Through Peer Support. My name is Catherine Reynolds and I'm the Program Marketing Manager here at Mental Health America's National Office, and I will be moderating today's webinar. A few notes as I introduce our wonderful presenter. This webinar is being recorded and will be emailed to you within 1 week of it ending. We do not offer CEUs, but if you would like a certificate of attendance, we can have a form for you to request one, and I will post that link in the chat. We have built some time in for Q&A. We're really lucky that Helena has joined us for live Q&A today. So as your questions come up, please feel free to put them in the chat box throughout the presentation, and towards the end, we'll leave 15 minutes to address your questions. And now I'm really excited to welcome today's presenter, Helena Plater-Zyberk. Helena Plater-Zyberk is the CEO and co-founder of Supportive, the digital peer-to-peer mental health service that serves over 2.5 million covered lives for health plans in large employers and has helped over 700,000 people cope with, heal from, and problem solve struggles like anxiety, depression, loneliness, social isolation, and stress. Supportive, the support network, operates 24/7, 365, matching users into professionally moderated small group peer support chats and connecting users in real time to precisely relevant support, tips, resources, and referrals. Supportive lowers the typical cost of mental health care by 10 times and delivers clinical grade outcomes in a consumer-friendly service. Helena is the former CEO of Simple Therapy, the AI-driven consumer-friendly service. The AI-driven at-home physical therapy alternative with no costly doctor or clinic consults, serving health plans, employers, and individuals. Formerly, she was an executive director of Scholastic Inc.'s Ed Tech business unit and a director of strategy and consumer insights at media behemoth Condé Nast. Helena holds an MBA from Columbia University. And with that, please welcome Helena Zyberk.
Hi, everyone. Since you were all so very kind to share where you are in the world right now, I will say that I am in Oakland, California, and I'm thrilled to join Catherine and Mental Health America today for what has turned out to be an extremely timely topic. We had planned this webinar starting a couple months ago, and then lo and behold, last week, the Biden administration and the White House announced the new National Mental Health Recovery Strategy, and peer support was highlighted as one of the projected areas of scalable ways to address the national mental health crisis. So here we are a week later, and perfect timing. Catherine did an incredible job introducing me, so I don't need to say much about myself, but I will just delve into a little bit more about what is meant by Supportive, which is a company that I co-founded. Like Catherine highlighted, we are a peer support network. We operate entirely online. So it's an anonymous chat-based network, and present day we work with large employers and health plans that want to offer this, but we're growing incredibly rapidly. We're adding month over month tens of thousands of new members to the network. Right now, our median age user is about 46, although we serve all ages from teen to well beyond sort of retirement Medicare age as well. In fact, we've just brought on a new Medicare supplement plan as a partner. So we operate around the concept of natural language processing, which means that people can just come and say what's going on. The word can be, they can say anxiety, they can say a phrase, they can say a paragraph. It's all typed into our little chat. And we use that to match them with other peers going through that same shared lived experience in that exact moment that want to talk at the same time. Then we keep it safe and we keep it on track and we keep the conversation productive towards a goal by having each of the conversations moderated in real time by professionally trained individuals so that peers are not left on their own. I don't want to get too much into that because I want to dive into the rest of the presentation, but I just wanted to offer that as my background and be clear, I'm not myself a clinician, but I'm going to draw upon a lot of the data and insights that are provided by mental health professionals, experts, and clinicians as we go along. So to set the stage, we are living in extraordinary times. We might call them terrible. For the past 2 years, we've been grappling with this impact of constant fear, constant social isolation. And amid all of that, we've had extraordinary numbers of outbursts of racial attacks. We've had violence. We've had the Black Lives Matter movement come to the fore because of racial-based violence. We are now amid a geopolitical war. We've had U.S. political instability to, come to terms with. We've had numerous environmental catastrophes, and we have these work expectations that we're going to be reachable all the time, even though many of us have taken on parenting and caregiving responsibilities like never before. So this is the world that we are operating in right now. And just recently, there's been a little like hubbub in the news about, is this trauma? Are we just living through a terrible time, or is this trauma? And the New York Times last month delved into that, questioning that piece. Actually, it was even before that addressed in The Atlantic in October of last year. That did a piece that delved into this concept of trauma and tried to make sense of this situation. So I thought it interesting to review that, originally the word trauma is a Greek word for a wound, physical wound. And this concept of post-traumatic stress disorder, PTSD, which has come into the vernacular, actually only dates back about 40 years. It was, applied after the return of soldiers from the Vietnam War. Trauma then has continued to take on additional meaning. So it's not just that physical wounds and the trauma of war for soldiers, but the number of acts and attacks and violent acts have expanded. And now it's sort of been taken on a definition from the American Psychological Association as an emotional response to terrible events. And they give samples like an accident, rape, or natural disaster. But as The Atlantic points out, that's just like those events, not only those events. The definition certainly can be expanded. So here is where our take on it is. Is the pandemic trauma or not? And we say yes, because this is something that is happening to us that we do not have any control over. We have no autonomy over what is happening or when it might end. No matter what we do, we can't make it better. We can't make it stop. Our piece of the puzzle is tiny. Has this impacted our lives? Yes, profoundly. Many of us for the worse. And there is a concept already known as a collective trauma, which means it's something that is shared and experienced by many people. Yes, that is what applies in this situation. And in fact, it is still ongoing. We may be heralding the end of mask mandates in some states, but that doesn't mean that we've seen the end of COVID. It doesn't mean we've seen the end of the impact that it's going to have. And in fact, this impact is going to be lasting and something that we've got to work through. That's, let's call it the mass population. We also have a really profound issue among frontline individuals of vicarious trauma. So this is something that's known in the medical services and in first responders for people who are assisting victims. And that they take on that trauma and they carry it with themselves vicariously. So there are discrete segments of the population that have a compounded issue. Now, there's another term that's been bubbling around that is getting a little overused, and it's resilience. And it's particularly getting used in workforce places where, employers have a vested interest in getting, employees back energized and back out there. And so they're introducing a lot of resilience programs. And what we're hearing when people are coming in and talking very openly in peer support is that they, that this is a sheen painted over a situation that actually needs more profound help. So I want to draw that difference. Resiliency is that ability to I won't say but to bounce back. Whereas post-traumatic growth is really a process that someone goes through when they don't necessarily feel like they can just bounce back. They've got to address what has happened. They've got to do some digging. They've got to kind of scrape the scabs and the wounds and actually potentially feel the impact of what has happened and come out the other side with a sense of purpose and personal growth from what has happened. That said, the label here is not necessarily the most important part. I don't want to fight with anyone about what is resilience and what is post-traumatic growth. In fact, it is my personal belief, and I'm citing someone here who is a medical doctor, that labeling these terms and labeling mental health conditions shouldn't necessarily be the goal. These labels that are required came to be oftentimes because a diagnosis is required by, let's say, insurance companies for treatment. That label does not mean that you're getting the treatment. It can be a first step, but let's just focus on what the goal is. And the goal here is the healing part. How are we going to get to the healing component of what we need as a national society? So, the go-to answer and what seems like easiest, let's see here, what's the image? There we go. Antidepressants and anti-anxiety medication. We've seen the headlines. They have been shocking. So the trends were, these numbers are maybe not even up to date because as I tried to pull numbers, the most, recently available ones were actually from midway through the pandemic, looking at sort of that first wave. I'm sure that we would see higher numbers now that we've entered 2022. This, though, is a really interesting take, which I hadn't seen before, which is that the vast majority of these prescriptions are coming from primary care physicians. And I love primary care physicians. I feel like they are the underdogs of the medical world. They are overburdened more so than a lot of other specialties. But their average length of a visit is 18 minutes. And in that time, I would say that we can all, conclude that this is insufficient for an actual, medicalized diagnosis with an ongoing treatment and care plan. So what we're ending up with potentially is an over-prescribed population with medicine that's designed to mask the symptoms rather than address the roots of our issues. Here's another doctor whose, I think, take on the situation is very apt. Mental health problems can be, episodic. And in fact, that's what we're talking about today. When you experience hardship, loss, maybe your, closest relationships are falling apart. These don't necessarily require labels of illnesses or conditions that, part of the mental health system is designed to apply. These things are situational struggles that can be addressed with something like peer support. Here's another psychiatrist over in the UK from the NHS. Psychiatric drugs are not designed to repair structural and systemic damages from inequality, from injustice, from disadvantage, and from discrimination. And peer support is a modality that actually then can get to the heart of these factors. Let's move on to the next, let's see what's going on there. There we go. The next kind of, go-to solution. So after medication on a population level, there's a lot of calls for therapy for all. In the past 8 years, some 20,000 mental health apps have come to the Apple and Google health stores. Claiming to be panacea, if we can just connect you to therapists, this is, and if not in people therapists, then robot therapists. If we can just get therapy to all people, then that might be the solution. I am here today to say, whoops, what's going on with the slides here again? It's not realistic. Yes, I have nothing against therapy. Yes, many-time therapy goer in my life. Kudos to all licensed clinicians on the planet, but it is never going to be a realistic solution for the population that we need to serve in the United States when 130 million Americans live in areas that there are, known professional shortages. And especially, there we go. Especially when pre-pandemic, extraordinary clinical provider shortages have already been forecast. This is some data, again, from the American Psychological Association of the dearth of providers that we think we're going to have among psychiatrists, counselors, social workers, psychologists, and school counselors. And these numbers are staggering. And these numbers were forecasted well before the pandemic, and when the providers that we do have are experiencing incredible burnout. This is a recent set of data that talks about college counseling practitioners, 90% are reporting burnout. 78% of psychiatrists are reporting burnout. So I think that the moment there is a let up in the steady drumbeat of demand for these services, we're going to see people exiting the profession. We may see fewer people entering the profession. I hope not, but that is something that we have to take a closer look at as a real possibility. Now, there are ways that the clinician shortage can be addressed. One, I think that, the insurance reimbursement rate situation is abysmal, and that's far beyond my means to address, but I think that there are smart people that are pursuing that angle. Subsidizing or lowering the cost of clinical training is part of the new White House National Mental Health Recovery Plan. So that's an excellent move in the right direction. There are issues with cross-state licensing. We could have a national licensure system, which would address some of the rural disparities, and that would be a great step in the right direction. There's a potential for tapping retirees and getting them interested in a second career. And there's definitely room for improvement in BIPOC representation among providers. And so let's talk about that, because that's an interesting also angle I want to get into as we talk about why peer support can be such a valuable resource, because it's much more appealing to those in underrepresented communities. So first, according to the APA, 86% of psychologists in the United States are white. And this is one of the factors why therapy and why traditional mental health services, unlike peer support, tend to be underused by minorities. There are distinct cultural differences around seeking mental health support. There is a finally admitted history of racial bias that the APA really, put forth last year and said, yes, we recognize this has been a problem. Kudos for that, but it doesn't change the structural issue yet. There are barriers in terms of underinsurance, communication, internet access that still exist widely, even in the United States. And I think that this last point is incredibly important in the polarized political society that we're in right now, where the concept of an expert, and especially a medical expert, is, not something that is universally accepted. So there is this distrust around medical experts that can apply to psychiatrists and psychologists and licensed counselors that is a very real structural issue that isn't going to be addressed by additional emphasis and investment in the traditional mental health system. Now, as we talked about earlier, this kind of all ties together. So psychiatry in particular, although I'm trying not to distinguish between the elements here, is the medicalization of ordinary experiences. And among therapy, one of the most go-to treatment programs is cognitive behavioral therapy. It's the most studied, it's the most likely to be digitized and therefore accessible to the broadest mass population access. And studies have been done to show that this continual pathologization of bereavement, of grief, which we are going through as a society, is contributing and actually compounding the problems that people have with the mental health system. It's actually driving people away from seeking treatment. So that brings us to our main question for today is, are we on our own? If the traditional mental health modalities are not the pathway to post-traumatic growth, what else is there? And, as I strongly believe in what I'm here, the message I'm here to deliver is no. There's a way for us to gather together as a society and on a national level, on a mass population level of healing, we can expand upon what we've come to perceive as traditional mental health care treatments. Gosh, slides are really, there we go. And there's a lot of ways that we can do that we can build upon this base of knowledge that's there. One, as noted in the new National Health Recovery Plan, community-based mental health services can be expanded dramatically. And I am completely in favor and pro that, although I'm not an expert. And so hopefully that can be a topic of another webinar. There's extraordinary amounts of research coming out right now on alternative therapies. And I include here ones that are not legal in all states. The data is pretty compelling. And I think that we're on really, this horizon or this verge of extremely interesting insights and exploration into this field of study. I'm adding nature therapy here because this is something that is well known and extraordinarily important to the well-being of a lot of global societies. You look at Japan, or you look at Scandinavia, you look at continental Europe, and what you find is actually that nature walks are part of prescribed physical health, not just mental health plans from doctors. You will see people getting prescription notes that you must take a 30-minute walk because the impact is so profound. And I think that that's another avenue for us to explore here in the United States. But what we're going to delve into for the next few minutes before we get to some Q&A is really how peer support can support this concept of national post-traumatic growth. So when we talk about peer support, there we go. I want to define it first because there are a lot of apps, first of all, organizations kind of hanging up their shingles right now, claiming to be peer support organizations and tools. And it's not always the case. So I think that what's critical, this is a definition in BMC Psychiatry from November 2020, that peer support is about the mutual exchange, that give and take between people who identify as peers on the basis of shared or similar experiences of mental distress. You've heard that concept, shared lived experience, and that's where this comes from. That is critical to the definition of who is a peer. And who is a peer for you can change at any given time. A lot of organizations and particularly employers think of peers as, people among their workforce. So if you work for this company or you're a member of this health plan, like everyone else who works for this employer or is a member of this health plan is your peer. And I don't agree with that stand. It's not necessarily an occupational concept unless your occupation is defining the trauma that you want to talk about that day. Yes, a first responder may need to talk to another first responder about a work issue, about things that they've seen. However, you can be a first responder and want to talk about parenting a teenager with ADHD. You might want to talk about caregiving with your mother who lives, 3,000 miles away that you're deeply worried about. And the best person for you to talk about might not be another first responder in that situation. It might be another parent with a teenager who has ADHD, despite the occupational commonality. It's going to be somebody else who has, a long distant parent within their declining health that is going through that same experience, not necessarily just another first responder. So the definition of peer support, I think, is very important, but the concept of who is your peer for the struggle that you want to talk about is constantly changing. So why? What do we know about peer support? This is a really valuable channel that is worth investment and exploration because we already know it works. You think about, the profound impact that Alcoholics Anonymous makes by bringing together people who are living through recovery together. You think about the profound impact of grief support groups for people who have suffered a loss, and how those other people that are living through what they're living through become the people who provide them that understanding and that acceptance of what they're going through. This is a concept that can be expanded across all topics. And in fact, it's been studied already in applications for depression and anxiety, and found that it can have on par, or in some cases actually exceed, the clinical outcomes that can be generated by things like cognitive behavioral therapy because of the power that it delivers. These are some testimonials that we've pulled from our own, vernacular that people give us after they leave peer support sessions. And we get it described often as, the feeling of a hug. I went in there, I didn't know what to expect. And for the first time, I felt like I was seen, I was heard. They understood exactly what I was going through. They calmed me down, they listened. They changed my life because they cared about what I was going through for that discrete amount of time that I was able to connect with these other people. So what we like to emphasize about peer support is that this is for real people, and this is about real solutions. This is not, frameworks, and this is not philosophical musings on what's going to help. This is about people giving and receiving help, because they mutually respect each other. They mutually feel a set of agreement about what is going to be helpful. You're able to see what other people around you maybe need before you even can see that for yourself. That's when it's kind of like having a mirror held up to you, and you're like, aha, like I'm able to help this person, and I'm inadvertently helping myself. And so the concept of peer support is completely evidence-based, and it's built around numerous social and behavioral theories, including social support, experiential knowledge, helper theory principle, social learning theory, social comparison theory, and self-determination theory. I want to get back a little bit more into why peer support is so important among marginalized populations. So this is a really, so all my citations are disappearing. There we go. This is pulled from the executive director of Being, which is the Black Emotional and Mental Health Collective. And this person was asked to delve into why peer support is so trusted, why it's accepted in their community, why the engagement is so much higher than traditional therapeutic modalities. And the origins of the trust of peer support, according to this individual, can be traced back to time of slavery, when there just was absolutely no access to any other emotional support other than in your community, in your most localized community. And they called it village care. So, it's about how to bind together and how to aid each other in suffering through something that is traumatic, and, coming out on the other side in a survivable state. This was the roots. This is where the origin of this trust came, and it's been a constant evolution conceptually and in sort of terms of care ever since. Here is some citations. Gosh, there we go. Oh gosh, and now I'm not even going to be able to read what's on my own screen because it's so tiny. But this is just, the loud sounding of voices that you'll hear on social media platforms in support of this, oftentimes also are pointing out some of the distrust and the inherent, fear that exists towards the traditional modalities. And this person says, why can't we just talk to each other? Why can't we just reach each other and help each other? And yes, we can. We absolutely can do that. So one of the big advantages of peer support is that by giving and taking, you're deriving human purpose, which is in and of itself an uplift. I mean, it's one of the antidotes, if you will, to depression. Is if you think of depression as that state of hopelessness, that state of despair, of there's nothing worthwhile anymore. The antidote to that is my depression, my feeling of hopelessness, my helplessness, and expressing that is actually providing relief and help to somebody else so that they know, okay, I'm not, that mantra of I'm not alone, like here's somebody who accepts me and understands me. And then that kernel of purpose expands and actually becomes a driver for re-energizing the individual. Now, as I mentioned earlier, there's sort of a cacophony of peer support options. So, as you may want to take a look at what's out there, here are some guidelines that we would recommend. So, primarily, number one is this, service or is this interaction designed or built around venting? Or is there a structure and a goal to the interaction? If you think about, again, going back to Alcoholics Anonymous meetings or grief support groups, there is a structure. There is a led facilitator who is, self organized and is providing that sort of guidance and safeguarding to the group. That is a really important component in making sure that the output of the conversation isn't just a downward spiral of negativity. There needs to be that structure in place to keep the conversation aiming towards a productive end. Who are the peers? So there's suddenly, dozens of organizations out there that are popping up saying, okay, we've got some volunteer listeners or even paid listeners, and we've trained them with active listening techniques, and now these are peers. And I would suggest being wary of organizations like this, because those people do not necessarily have that shared lived experience. It is, there can be some therapeutic value to having somebody listen to you, talk about what you're going through, but you're not going to get that give and take. You're not going to get something back, and you're not going to get that sense of purpose for helping that person. There's just a lot missing to that interaction. I think that anytime people are together in a situation that is fraught with mental health distress, there needs to be assurances for safety measures. So one, if it's an online forum, we know the prevalence of trolls in all forms of online communication. Even in these, potentially these benevolent interactions can quickly turn negative. And then either in person or online, what are the protocols for crisis escalation? Are these services equipped to handle it? Can they route people to crisis intervention in an immediate manner if that's what the situation entails? Who is detecting that there might be a crisis? These are all things that you're going to want to be examining. And then lastly, what time of day is this available? So I think the last thing that the world needs is another service that's available from 8 a.m. to 5 p.m. Because what our data has shown, and I'll show you this on the next slide in a minute, is that emotional distress is not confined to business work hours. This need for peer support is going to arise around the clock. And as we build out these structures, we want to make sure that that's when they're available to meet needs. So I want to go back to a little bit about supportive and what we've been building. On the right is what you already saw earlier, but on the left, I want to tell you a little bit of what we found from our over 750,000 users so far. So the most active hours when people are seeking peer support tend to be about 8 p.m. to 2 a.m. and then weekends. So Saturday and Sunday are the highest volume days, and those are when we're seeing the most need. Of the self-reported data that we've seen, it's been incredibly interesting to see how many users are actually male. I think many people are aware how difficult it is to get males to engage in mental health treatment. Among therapy, for example, it's almost like 85% female, 15% male patients, whereas in peer support, we're seeing a much more even distribution among male, female, and non-binary. And this is all self-reported data that's coming from people after they've used our chats. In addition, because our goal from day one has been to serve these expanded, underserved, like marginalized communities, 58% of our professionally trained chat moderators are non-white, which is, I'll go back and compare that to the APA saying 86% of psychologists in the United States are white. So a huge point of differentiation. Our average chat length is about 27 minutes at this point in time. And 42% of our users are coming back. And those who come back are coming back an average of about 6 times. And that's split, 1/3 coming back for the same type of struggle, maybe chronic anxiety or chronic depression, but 2/3 coming back for different struggles. So maybe one day you need to talk about, trauma that happened at work as a frontline healthcare worker, but the next day it's that, parenting a difficult life stage challenge. The next day it's that caregiving for your elderly parents, question. And so people are seeing that they can come back and get matched up with people across an entire spectrum of need. So to get back to the goal of today and post-traumatic growth, what I want to emphasize is the diversity of the experience that, or not diversity of backgrounds that people bring to the table. So what we've created in a format that is anonymous and chat-based is something that really transcends age, gender, racial or ethnic background, occupational background, socioeconomic education levels, because the truth is that in today's world, whether you hold a PhD or you hold a, not even yet a high school diploma, we actually all kind of chat and text the same. There's not a lot of, grammatical pickiness. There's not a lot of assumptions that can be made about people's backgrounds in the way that we as humans make judgments about each other. So we're stripping away these things that are skin deep in terms of, I might think that my peer would be another middle-aged white woman, but the reality is that online, when nobody knows I'm a woman and nobody knows I'm white and nobody knows that I'm necessarily middle-aged, unless I'm talking about a struggle that's related to that cohort, I can be talking about anyone. I may have lost my beloved pet who's been with me for the past 10 years, and I can be a 70-year-old man and I can be a 16-year-old girl. And there is actually no danger in that interaction happening. It is a pure interaction. And that's what's applicable to this COVID era post-traumatic growth. What we have all been through, yes, there are segments of the population I want to absolutely recognize that have seen incredibly more hardships. I'm not trying to take away from that, and I acknowledge that. But that those demographic factors don't need to be, the definitions of peers. Again, we eliminate these structural demographics, and we can actually bond as peers about the trauma of having gone through the COVID era on the basis of the mutual experiences that we are discussing and that we need help with to process, to cope with, to heal from, and to grow. What happened there? Sorry, got some weird slides there. Okay, last slide. I just want to talk about what post-traumatic growth means. So these are some of the recognized elements. So it's rediscovering an appreciation of life. It's reforging relationships and social connections with others. It's understanding that there are new possibilities out there that are awakening in us. It's re-recognizing that we have personal, strength and ability to adapt. And it's perhaps recognizing that there's some spiritual change. The way that we perceive the world and how things should be versus how things are new experiences for us, and is going to color a new way that we are going to see the world from now on. And these are all discussion topics that we are seeing happening right now. And these are leading to profound changes and enlightenment of the people who participate in these peer-to-peer support discussions. So I think actually, I've finished up a little bit early, and that leaves us some more time for Q&A, and I'm happy to field any questions that may have arisen.
Yeah, thank you, Helena. That was great because we actually have quite a few questions. So I'm happy that we have a little bit more time baked in for some Q&A.
Okay.
And everyone, feel free to keep posting some in the chat. I've collected a majority of them, but we'll see how many we can get through. So some of the first questions that I have for you are really kind of focused on Supportive's platform.
Okay.
And Paula, I see you in the chat. I will address that, the URL for the certificate of attendance. So some folks are wondering, how are the interactions on your platform moderated? Are there clinicians involved, or is the peer support moderated by other professionals, or how does that work?
Yep, thank you. So we have taken a little bit of an atypical model here. So first and foremost, our goals with Supportive were to be, mass availability as quickly as possible and scalable in the sense of being able to address as many people as possible. So instead of a typical one-on-one interaction between an individual and a peer support specialist who has, gone through the certification process in, let's say, eating disorder recovery, as an example. Our moderators go through a training program, which I'll describe in a moment, which makes them master facilitators. They are the ultimate generalists, because what that enables us to do is have the peer designation go to people who are the seekers of the support, who are coming to the platform saying, my struggle is X, and we're matching them together with our trained facilitator, sort of, masterminding that interaction. So for us, our moderators are actually psychology students. They're not licensed clinicians, and that's what makes this, affordable for pennies for large organizations. We started tapping into psychology students in the US because we're in Oakland, California. We started with Berkeley and Stanford as our first two universities, and then we grew to, recruiting across the United States and then internationally. So we have psychology students, masters, PhD level even, from India, from the Philippines, from a lot of English-speaking countries all around the world, which is what makes us able to serve 24/7. And we created a training program in collaboration with our clinical lead out of Stanford University. He's a PhD clinical psychologist by the name of Dr. Alejandro Martinez. He actually ran the Stanford mental health system for 17 years. He created a peer support program on campus. He's created 2 courses at Stanford on peer support. And so he built for us this sort of master moderator training program. It takes about 4 months. And it's teaching them, we actually start with active listening, which is where a lot of organizations start and end, but we build from that into other models for facilitating conversations, for collaborative problem solving, for introducing coping tools and healing techniques and workbook exercises into the conversation in real time as the conversation unfolds. And then they also have the ability, actually, maybe I'll leave that as one answer, and then I'll come back to this if there's more questions.
Well, thank you for that. And, some people, maybe I should leave this question for last, but I thought I could just get the ones about your platform, over with now. People are interested in, are you currently hiring peers, or how can people apply to become a peer specialist?
Mm-hmm. Yep. If you go to here, I have the web address on the next slide. Let's see. If you go here to supportive.com, and it's supportive with no E, SUPPORTIV. Under the FAQs, there's actually a link to how do I become a moderator, and it will lead to another page that talks about the position and has an email address for job applications, which is moderator@supportive.com.
And is this service free to participants, or is there a cost associated with your users?
Yeah, so the first visit is free. So anyone can come to supportive.com and give it a try. And then after that first visit, yes, there is a cost. It's $15 per session.
And how long are those sessions?
Actually, so sorry, the $15 is, I should explain, it's an unlimited number of sessions, so in a 24-hour period. So you can chat as long as you want. You can chat for hours and hours.
All right. Thank you. And we have another question. So what are your thoughts on the future mental health of children that grew up in the pandemic during this formative time?
Yeah, I mean, I will preface this by saying, one, I'm not a licensed clinician, and two, I'm not, a child psychologist expert, but I think that we can universally recognize that the experience of children over the past few years has been profoundly different than the childhoods that any of us today have experienced. These concepts of, sharing and reciprocity and communication development and independence and self-sufficiency that are all present at different age stages of our lives have been ripped away for 2 years. And I think that we're going to see, social development delays that are really impactful. And I do not have a prescription for how to address this, but I'm glad that a lot of people are thinking about this and a lot of people are working on it.
And we also had a question about how this service will play into the implementation of 988 nationally or on the state level.
Yep. So that would become part of a tweak to our crisis routing protocols. So right now, a couple things happen. So one, I want to say that supportive is completely capable of handling and having these guided conversations with people who are passively suicidal. But we do language detection and human detection for people who may be actively suicidal. And we, in the chats, will introduce a protocol question, which is, do you want to kill yourself today? And so it's setting that time frame and that action determination. If somebody answers yes, or if there is a non-answer to that question that we have to count as a yes, the moderator will at that person in the chat and say, we want you to get some one-on-one attention right away. And actually that person's chat screen will change. So it's a technological intervention. So they are actually, their screen changes from the chat out to a screen that has the options for the National Suicide Prevention Hotline, the crisis text line, any crisis services that are offered by some of our institutional partners. And then we would be adding, potentially the 988 as services that people can utilize that offer that, specialized resource.
Thank you. And we did have a question. Do you have any ideas on how metropolitan urban residents could utilize the nature therapy that you gave an example of?
Yeah, so I don't have the data on the tip of my tongue, but I've actually done a whole separate presentation on that. And there are actually studies about just walking by trees that are along like boulevards and some busy streets and traffic, that it's not actually, that the benefits of nature exposure doesn't have to be in an isolated forest. It's literally just seeing a tree or just seeing a plant. And in fact, I think there's studies right now about exposure to artificial plants and whether that actually has the same impact. And so one does not have to feel discouraged if they are bound into a metropolitan area, that the positive impact can still be there.
Thank you. And another question, someone asked, will the peer supports specialists need to be certified when the time comes as states are starting to put in place their own certification processes? So this person was asking about in the state of California, but just kind of generally, will your peer supporters need to be certified as states do that?
So that is on sort of our roadmap. I will say that the have to be certified, and this is my understanding, which may be incomplete, is for services that are looking for reimbursement through things like Medicaid or Medicare. And so there are different requirements for those type of state or government-based services versus individuals. So I think that what we're looking towards with the supportive is sort of a hybrid offering where, yes, certified peer support specialists will be able to be drawn into those conversations that serve those organizations and models, whereas the format that we have today might still be, perfectly capable of addressing other types of organizations that don't have those stringent requirements, especially because in the format we have today, we're already getting clinical grade outcomes like reduction in PHQ-8, like reduction in GAD-7, like, sentiment improvements across populations. So the impact is already there.
Thank you for that. And kind of along those lines, we do have some people wondering about insurance and if insurance helps pay for this.
Yeah, I mean, that's the vision. So today we work with one of the major national health plans. We're not at liberty to announce that yet, but we are in talks with a number of health plans. And the absolute ideal state would be availability of supportive that is sponsored with zero copay through all health plans. So that's what we're working towards.
Great. And Helena, someone asked earlier, are you yourself a peer?
Well, for us, I don't moderate on the platform, just sometimes what people mean. Have I gone on as someone, as we call the peers of people seeking support? Yeah, I drop in all the time. I like to, be a user. I actually have dropped in for example, like romantic relationship issues, just to see what people might have to offer to me. I think it's, you get that fresh perspective, you get that uplift, you get that, people care, people listen at odd hours. So the benefits are just as applicable to everyone.
Thank you. And someone was wondering, is there a reason that you only use psychology students, or are the people working on your platform, are they also from, social work or counseling?
Oh yeah, so social work and counseling, yes. I think that we just haven't updated the definition, which we should, because it started that way. So that's sort of our historical roots. And actually going forward, we're looking about having kind of our own vetting mechanisms for what we're calling inherent rapport of individuals, so that you don't even necessarily have to have that psychology or social work or counseling background or training, as long as we think that you are malleable through our training program.
And when individuals use the platform, do they speak once they have access to it? Are they speaking with the same individual, or are they being connected with others?
Connected with others. So it's for those people who return, you're always going to be connected in that, under 1 minute, zero wait time, to the most relevant and similar peers that are online at any given moment. So yeah, it is going to be a different group each time. And that's sort of, the trade-off that we made to appeal to the needs of immediacy that we have in, 2022 versus something else that we're adding to our calendar that's every Tuesday at 7 p.m. that, doesn't really work with the way that our lives operate and isn't the most friendly format. So we did have to make that trade-off, and we went with the dynamic immediacy.
Thank you. And I was wondering, could you speak to the differences in the types of peer support? And, is your platform appropriate for people of all ages, or can you tell us more about that?
Yeah, actually, so we get questions a lot about teens. So we do, as an online service, we do only serve age 13 and up. So if someone is under the age of 13, which we can identify sometimes through language, or we just ask them, if they've gotten into a chat, we will direct them to other youth resources. So we have the same way that crisis referral screen change will happen. We'll have like a youth referral screen that will happen. We actually have built in language modeling that can detect people between the ages of, say, 13 and 18. So depending on the cadence and kind of the communication style and even the struggles that people enter when they're asked, what's your struggle? Our model will ask you one single question, just if we think that you are between 13 and 18, which is your best peer match a teen? And people who say yes are routed into distinct team-based chats. That question, infrequently comes up, but we do make use of it. And then I think, could you repeat there was a second part of your question about different cohorts, right? Or was it just about age groups? It was about age groups.
Right.
I will say that we also, sorry,
kind of specifically, I mean, would, adult peer support for an adult who's also a parent, or are they the same service, or are those, different? And how do you feel?
Yeah, so it's all the same, and you don't have to self-identify. So we would figure out that you are a parent only if your struggle is related to parenting. So if you came in and you said, my struggle today is, a rowdy teenager, we understand that through our natural language understanding to be that you are a parent, and we're going to match you with other parents that have, children in your age cohort. If you were to come in and say, I have my job review tomorrow, and I'm worried about a promotion. That's a clue. That's another language clue about what stage of your life you are in. But we're just looking for clues. It's that context. It's that capability of understanding from millions and millions of data points that we've developed. You don't have to fill out a demographic survey. You don't have to say I'm a parent and whatever. We are eliminating all of those steps that other platforms and solutions require, because we've leapfrogged over that, and we're starting with a basis of understanding that we think that meets consumer expectations in a way that many haven't seen before.
Thank you. And I know we just have 2 minutes, so maybe we have time for one or two more questions. We have a question. Is there any sort of tracking, or what sort of tracking do you do, gauging people who might be having suicidal or, homicidal ideation? And how would you involve, if necessary, others?
Yeah, so I talked a little bit earlier about the protocols for people. We do have protocols in place for, criminal activity, like you just mentioned. Over and above the distinguishing between actively and passively suicidal, we have it for domestic violence, we have it for sexual assault. So these are little protocols that the moderators are trained in, and that will appear in the chats as prompts to them. And then it's kind of like a decision tree, because we're a technological solution. Once we've, put a user into the protocol and determined, the binary yes, no, is this a crisis situation or not, we are then triaging and navigating people who are in crisis situations to other more appropriate services, and out of kind of the general pool type service that Supportive offers.
All right. Well, thank you so much, Helena. I think we can stop there. I will drop that link to pick up and I'll just remind you, we do not offer CEU, so it's just a plain old certificate of attendance. And thank you so much, Helena, for everything you shared. So much value came from what you had to say, and we're really fortunate that you shared about your experiences with us today. We'll be in touch with everybody in the next few days to get this presentation over to you, and the link to request your certificate will also be included there. And we really appreciate everyone joining in the really lively chat, and have a great day, everybody. Thank you.
Thanks, everyone.